Welcome back, Dr. Bakare. Um, Now, in the first section of this interview, you mentioned preventive care, and you talked about cervical cancer and the advancement in cervical cancer prevention, and the fact that you've done a lot in that area. But then, in the area of mammogram, I was going to ask a question on that. When would you advise a woman to have a first mammogram?
Well, generally now there is a consensus that the first thing you do is identify risk factors in the patient's particular history, vis-a-vis family history, the history of their menstrual cycle. But the general consensus is mammograms should be done regularly after age 50. There was a time 10, 15 years ago where we thought there was value in doing a baseline mammogram at around age 35. And that if it was normal, then you wait till age 50 and do them regularly. Now, the general agreement is we should just begin mammography at age 50. The current recommendation by the American Cancer Society is to do mammography every other year in a low-risk patient after age 50. In women who have high risk, like a family history, and when we say family history, we're talking usually history of breast cancer in more than one first-degree relative, which would be mother, grandmother, sister, daughter, that sort of thing. In such women, it may be necessary to do them every year.
Okay.
And even in such women, depending on the risk factor, you may have to begin the mammography long before age 50. You know, one thing we didn't address is one common thing that we also deal with is contraception.
Okay.
You know, in preventing pregnancy, unwanted pregnancy, and I'm sure you know there's controversy every which way you can slice it based on religious affiliations. But in general, we encourage most young women who are sexually active to use contraception. And this has been very, very helpful in the declining rates of teen pregnancy that we're now seeing in the population. Infertility is a very confounding subject. Depending on what studies you read, about 5 to 12% of couples are infertile. And the cause of infertility is as often in the male as it is in the female. There's a general misconception that when there is infertility in a couple, it's usually because there's something wrong with the woman. But what we in fact find is 40% of the cause of infertility is in the female, 40% of the cause of infertility is in the male. And in about 10% of cases, it is mixed, where the male has a problem and the woman also has a problem.
So do you think males are well educated about these statistics?
No, not at all. Most men, in fact, don't want to be part of the process. When the woman presents with difficulty with getting pregnant, the partner or the husband usually feels it's the woman's problem to find out what's going on. But what we do in our practice is be assertive enough to let the man understand that they need to have at least a basic investigation to establish whether or not they do have a problem. And it's very simple. It's a very simple semen analysis would help determine whether the man is in the picture or not. And that would allow us to concentrate on the female if we can immediately exclude the male.
Now, there's been a lot of advancement in the area of infertility investigation and treatment. Can you educate us about that?
Well, there are very many causes of infertility. The problem can arise with at any point in all the factors that are involved in pregnancy. For a woman to get pregnant, 3 basic things must be in place. The woman must be able to produce and release eggs, which we call ovulation.
First, she must be able to have sex. She must have sex. Because there are a lot of people that they want to be pregnant and they're not having enough.
Exactly. The sex pact is taken as a given.
But you'd be surprised that some people, they want to get pregnant, they have sex once a month.
Yeah, and that's actually quite important, because a woman's ovulatory cycle is such that a normal woman who is functioning normally will release eggs once a month. And once that egg is released, it is viable only for about 24 hours.
Wow.
So if pregnancy does not occur within that 24-hour window, then you have to wait till the next cycle. Now, fortunately, the sperm lives for about 72 hours. So if a couple, say, was sexually active 2 days ago, and the woman happens to ovulate today, that intercourse of 2 days ago can still result in pregnancy today.
So is it important for them to be able to know those critical
Yes, once a woman has a problem, it's important to be able to have a good idea of when that ovulation is likely to occur, so you can advise the couple on the frequency of intimacy around the time of ovulation. But in the normal course of everyday life for most people, it is unnecessary, because couples who have a normal relationship, who are generally sexually active 3 to 4 times a week, you don't have to pin down the day of ovulation. Chances are that, they would fit into the day of ovulation in their normal course of daily life, because being too regimental about the day of ovulation can also be counterproductive, because then they're so conscious of it, and a lot of other hormonal factors feed in to prevent pregnancy. But in the general course of normal everyday life, most people, generally would not miss. But when a couple has a problem, it's important to be able to identify that date so you can advise them as the best window of opportunity for pregnancy. But going back to the different causes of infertility, difficulty with ovulation can result in infertility. I was talking about the 3 main ingredients that have to be in place. Is that the egg has to be produced, the sperm has to be able to swim and travel, and the path of travel has to be clear. In the normal case, the sperm is deposited into the vagina, usually in the tens of millions, And then many of the sperm have to be able to swim through the mucus in the cervix, travel through the cavity of the uterus, and then into the fallopian tubes. Because it's usually in the fallopian tube that pregnancy occurs. So the egg is traveling down the tube, the sperm is traveling up the tube, and somewhere around the middle of the tube, they would meet, and then pregnancy results. So those three factors have to be in place. The tubes must be open, the egg must be produced and be good, and the sperm must be able to swim.
So and those three aspects have to be investigated?
Yes, so those three aspects have to be investigated. And when a couple has a problem, the problem is usually located in one of those areas. Either there's a problem with the sperm, not just in terms of numbers, but in terms of the quality of the sperm and the ability to be able to swim.
Okay.
Then the tubes must be open and the egg must be released. So in investigating infertility on the basic level, those are the three things that we're trying to establish.
Which one is the easiest to solve, or if there's a problem, of the three?
I'm not sure that I will use the word easy, but in terms of
because I see a lot of women going for, I mean, those women that all of a sudden they have triplets. They have been trying to get pregnant for a long time. Then they have triplets, and people say
the easiest problem to treat is if a woman is not ovulating, is usually because of some hormonal abnormality of some sort. And generally, we have enough drugs that can stimulate the ovaries to ovulate.
Okay.
And depending on what drug is used, you can actually stimulate the ovary to release a lot more than one egg. The first line drugs that we use to stimulate ovaries are not as notorious in causing multiple pregnancies. You may get twins with the first line drugs, but getting quadruplets or quintuplets or sextuplets is rare with the first line drugs. When you move up to the more sophisticated drugs is when you're likely to release multiple eggs and result in multiple pregnancies. Technologies have evolved to the point that when monitored properly in expert hands, even with those sophisticated drugs, multiple pregnancies can still be mitigated. And that's why when things get to that level, the patient should not be with a general gynecologist. They should be with an infertility and endocrinologist who is very knowledgeable in treating these conditions.
Okay. Hold that thought. We are going to, because this is a very interesting area, and we don't want, we want the viewers to really know about this. We're going to be coming back to talk more about it. Thank you very much.